End of the academic year, summer, and it feels like summer in New York today. In fact, it feels like North Carolina summer in New York today, not New York summer. Uh, but as there's a lot on my mind. Let me say the first thing that's on my mind. First thing that's on my mind is the Weill Cornell medicine community. This has been, in some ways, an exhilarating year, and in some ways, a really difficult year, as we've asked people to change the way of doing a lot of things. And people have really stepped up to the moment, and that's been fantastic. So the first thing that's on my mind is all the members of our community who have worked so hard to make this a successful academic year for the faculty, for the staff, for our trainees, for our students. Um, that's the first thing that's on my mind. The second thing is that I'm somebody who's always looking ahead, and I'm looking to the next academic year because while there are challenges ahead, there's also opportunities. There's opportunities to do things better. There's opportunities to think about our science differently. There's opportunities to think about how we take care of patients in better coordinated ways. There's opportunities to think about how do we teach differently? How do we do more multidisciplinary team-based teaching? There's so many things that in some ways circumstances of funding and finances might force us in a certain direction. But I look at that as not just a forcing function, but maybe strategic opportunities ahead. People always ask me when it's on my mind, what am I reading? Well, the next book I'm getting ready to crack in the next couple of days is Eric Topol's book on superagers, which is about why is it that some people are able to live into their 90s and hundreds with seemingly excellent health? What is special about them? What's different about them? On a future episode of Ask Bob, I'll try to give you some of the answers that I learned from reading Dr. Topol's book. When I think about what's needed in medical schools and academic health systems, I think that clinically trained people are really needed in healthcare administration. One of the things that healthcare administration suffers from, in my opinion, is not having enough of its leadership have to really understand the paradigm of clinical medicine. What does it mean to be a clinician? What does it mean to take care of people? What does it mean at a very visceral level when you talk about high quality? My business colleagues do a great job at running health systems, but they would benefit from having in their midst more clinicians who are trained in the business of medicine and the business of healthcare to help out. And so if I were to be given a mission, it would be, let's get some more of our medical students, some more of our residents, some more of our fellows and junior faculty interested in the administration of medicine and get them trained, get them some business training, get them some formal education. I would love to see more clinicians in healthcare administration. It's interesting when you look at the biomedical workforce, whether you're talking about on the clinical side or the research side, the real spread of learning styles, if you will. Part of that is absolutely generational. We have a workforce that begins in its 20s, and we have active members of our workforce in their 80s and 90s. You know that they learn differently. They grew up with different learning styles, different learning technologies, different learning tools. The example I like to give is when I'm making rounds with residents and students and fellows, and we're at the bedside and I ask a question. It's not uncommon to see somebody looking at their phone. I've learned over the years, sometimes because I wasn't so adept at figuring out what was going on, that they're not checking their text messages. Often what they're doing is trying to check the answer to my question. And they're looking at the literature. They're pulling up an article. They're pulling up guidelines. I think that is a real difference from my generation, who we would do something like, well, I'll go to the library after rounds and look it up. I think that the availability of tools at the bedside, tools in the classroom, really make for a much more dynamic learning style and atmosphere that we need to take advantage of that. Part of what is incumbent upon all of us to think about is how do we make sure we convey those different learning styles to the faculty, to the students themselves, so that people know, hey, it's okay to pull out your phone when somebody asks you a question. It's okay to say, hey, can I look this up in up to date right now? Can I look up a guideline that you just referred to? One of the funny things that's happened to me many times over the years is I reference an article that I might say something like, oh, it was an article in circulation 2 years ago. And moments later, a student comes back and says, Dr. Harrington, I think it was actually in JAMA 5 years ago. And so I enjoy that sort of feedback and getting pressure tested on the spot. One of the things that I think we in the science community have not done a good job of is talking about the scientific method, talking about how things like curiosity-driven research can begin with a question on one thing and end up years later with an answer to something else. It never ceases to amaze me that somebody will be asking a really basic, fundamental biologic question, and they are intrigued by that, and they pursue it for years in a series of experiments and studies that go on sometimes for many years. And then oftentimes somebody coming from another laboratory or even another discipline will look at those data and say, you know what? I wonder if we took that observation and went in this direction. I mean, there's a great Weill Cornell story here, and that we had two senior faculty members, Drs. Levin and Buck, who were studying a protein for the sake of their interest in the protein. Years later, did somebody realize that by inhibiting that protein, they could actually limit or inhibit the motility of sperm. And by doing so, they could create an just-in-time, on-demand male contraceptive. Now, that was not what they set out to do. But guess what? They're now in clinical studies trying to understand if this might be a valuable new therapeutic as a male contraceptive. I love that story because it points out that basic discovery research can end up with an application that's much different than the scientists might have originally postulated. In the Here's What We Know campaign, we're trying to convey just that. Given any science topic, what is it that we know today? Well, first off, let me tell you why we're doing it. It's clear that as we look at the uncertainties in science funding in this country, one of the things that we in the science community have done a poor job of is communicating to the general public as to the importance of what we do. We've not done a great job of making a link between here's basic discovery and here's a cure for cancer, or here's basic discovery and here's a step forward in the treatment of heart disease. To me, it's always been fairly obvious, those connections, but we've not done a great job communicating it. With the help of our communications team here at Weill Cornell, we're trying to address this head on. How can we help the broad public community understand what it is we do in science and why does it matter? And we're trying to do it in a way that's respectful, that's civil, that really takes into consideration the phrase meeting people where they are. We're not trying to say that this is everything we know about a topic. What we're saying is, when take measles, for example, which was the topic of our first installation of the Here's What We Know campaign. Let's just talk about measles. What do we know? What do we know today? What does the science say? Where do we think this is taking people with regard to things like vaccines, risk of catching measles, risk of transmitting measles, risk of getting very sick from measles? All of that information we want to deliver to the public, but we want to do it in a way that's understandable. The second installation, which is in my own area of research, is what do we know about clinical trials? What are clinical trials? Why do we do them? Why are they important? Why should we as members of the public care about clinical trials? So for me, this is an attempt for us in the science community to be better at communicating scientific topics so that the public perhaps can see the link between science and healthcare. Clinical trials are how we understand, does a therapeutic, a technology, a diagnostic, does it make a difference? I think of it as when you want to understand, is A better than B? Whether A is a new medication or a new diagnostic and B is the old way of doing it. How do we really understand that? And one of the lessons we've learned over the years is that you have to ask that question not as a thought exercise, but you really have to ask that question in a systematic, rigorous way. The randomized clinical trial is the gold standard. If you want to know if A is better than B, you have to randomize in the clinical setting patients to receive A or to receive B. And then what randomization does is it levels the playing field between the two groups, meaning the two groups should be, if the sample is large enough, should be similar to one another, same age, same proportion of men versus women, same risk factors, say things like diabetes, high blood pressure in my area of cardiovascular clinical trials. And then when you submit one group to A and one group to B, then at the end of the day, you can compare the outcomes in the two groups, and all of the difference that's found ought to be attributable to what they were randomized to and not to basic differences or baseline differences in the populations. Clinical trials are clearly essential in understanding human therapeutics and making forward progress. And here's a little interesting tidbit I've learned over the years, that patients who are enrolled in clinical trials get higher quality of care and have better outcomes than people who are not enrolled in clinical trials. And that probably has to do with the fact that we pay such exquisite attention to study subjects that they benefit in other ways. Their blood pressure tends to be better controlled if it's a cardiovascular trial. Their diabetes tends to be better controlled, even if the trial did not have to do with diabetes, but was in a related area. So clinical trials, important for progress. Clinical trials offer a lot of benefit for the patients who participate in them.